Good evening, everyone. Thank you for attending tonight's webinar. I'm Joel Brock from the Workforce Development Team here at Murray PHN. To start off, I would like to do an acknowledgement of country. Murray PHN acknowledges its catchment crosses over many unceded First Nations countries following the Dalkunya Yaluk. We pay our respects and give thanks to the ancestors, elders, and young people for their nurturing, protection, and caregiving of these sacred lands and waterways, acknowledging their continual cultural, spiritual, and educational practices. We are grateful for the sharing of country and the renewal that country gives us. We acknowledge and express our sorrow that the sharing has come at a personal, spiritual, and cultural cost to the well-being of First Nations peoples. We commit to addressing the injustices of colonisation across our catchment and commit to listening to the wisdom of First Nations communities who hold the knowledge to enable healing. We extend that respect to all Aboriginal and Torres Strait Islander peoples. On to some online housekeeping now. Please note your microphones and cameras have been turned off. Please submit any questions via the chat, and we'll address as many as possible with time permitting at the end of the presentation. And this webinar is being recorded. Onto some important information now. The information provided in tonight's webinar is for informational purposes only and does not take into account individual circumstances. Practitioners will need to make their own professional judgment on a case-by-case basis. And tonight's event is thanks to Murray PHN partnering with Wendy Young. Wendy is an accredited practicing dietitian and a primary care engagement officer for the LIFE program at Diabetes Victoria. She brings extensive experience as a dietitian, having worked across diverse primary care settings, including private practice and community health. Thank you, Wendy.
My name is Wendy, as Joel has mentioned, and I'm the Primary Care Engagement Officer at Diabetes Victoria. And I'm also an accredited practicing dietitian by background. So I'm really pleased to be here with you today to talk about a topic that is not only common in our practice as primary care health professionals, but is also one that has significant implications for women's health long term. So, in this presentation, we'll be exploring gestational diabetes, its risk factors, the important but often overlooked relationship with eating disorders, and how we as health professionals can best support women both during and also after pregnancy. This session is particularly relevant because gestational diabetes is increasing in prevalence here in Australia, and the impact itself actually extends well beyond pregnancy. And as we'll see, women who experience GDM often have higher risks for type 2 diabetes, cardiovascular disease, and also psychosocial challenges. So, our role in education, in screening, and also follow-up is critical. So this is just an overview of what we'll cover today. So first we'll build a bit of a shared understanding of gestational diabetes itself, and then we'll have a bit of a detailed look at the major risk factors and spend some time also on the overlap between some eating disorders and also gestational diabetes. And this is often an area that doesn't get nearly enough attention, especially as the statistics evidently show a large proportion of pregnant women being affected by eating disorders during pregnancy. And after that, we'll review the latest diagnostic criteria, walk through some management strategies, including what to do when eating disorders are present. And then finally, I'll also introduce the Life After Gestational Diabetes program, which is a fantastic resource for ongoing support post-gestational diabetes and is also a service accessible for Victorian women. So we'll just start with a quick poll. So I guess the first question I wanted to just sort of ask is how familiar are you with the new gestational diabetes diagnostic criteria? So you can just answer A, B, or C depending on what is most, I guess, appropriate for you in terms of your knowledge. So just take a moment to respond, and there is no wrong answer, so to speak. So it's just to help me get a bit of a sense of the group. Okay, so it seems like majority of people are somewhat familiar, and then I think about a third of respondents are not familiar at all. So that's definitely a very interesting sort of breakdown. And then obviously a portion of you guys are also quite familiar with the diagnostic criteria. The next question I also have, just to get a bit of a understanding of the room as well, is how confident do you feel managing eating disorders and gestational diabetes simultaneously? So again, just click A, B, or C, depending on which answer is most relevant for you. But yeah, just leading on from this question anyway, working in primary care settings, many of you will probably have actually come across individuals who have an active eating disorder in the community or they have disordered eating thoughts. And managing GDM alone is complex, but when we layer in some disordered eating behaviors, it can feel daunting to navigate. So today we'll obviously cover a little bit of that as well. And it seems like 60% of you guys are not confident at all. So definitely stay tuned in this webinar because we'll obviously go through a bit of that today as well. All right, so we'll move on from the poll questions and just start with obviously an overview of what gestational diabetes actually is. So, gestational diabetes, or GDM as it's often abbreviated to, is defined as glucose intolerance. And this is the glucose intolerance that begins or is first diagnosed during pregnancy. It can appear at any time during pregnancy, but it's often most detected in the second or third trimester of a woman's pregnancy. And this is simply because guidelines promote screening usually around 24 to 28 weeks of gestation. The current RACGP guidelines remind us that GDM is not simply a temporary condition that resolves after birth. So, whilst many women will return to normal blood glucose levels postpartum, the diagnosis of GDM places them at a significantly higher lifetime risk of type 2 diabetes and also cardiovascular disease as well. So, when we diagnose gestational diabetes, we're not just really managing a pregnancy complication, we're also identifying women at an increased risk for chronic disease later in life. And there's also a term that you may have heard, which is known as early gestational diabetes. So, this actually refers to glucose intolerance picked up before 20 weeks gestation, but that doesn't meet the criteria for pre-existing type 2 diabetes. And the distinction here is actually important because if a woman actually meets full diagnostic criteria for diabetes before pregnancy or early in pregnancy, that will be classified as type 2 diabetes in pregnancy rather than GDM. But when her glucose levels are in that sort of gray zone, not meeting the threshold for overt diabetes, but still above normal, we would label it as GDM. So when we have a look at the data, this figure from the Australian Institute of Health and Welfare shows the incidence of gestational diabetes by age group from 2021 to 2022. And you can clearly see that maternal age is a major factor. So women aged 35 and over are between 2.5 to 4 times more likely to develop GDM during their pregnancy compared to younger women. And this trend is obviously very important because in Australia and also in many other countries, women are increasingly having children later in life. Therefore, an increase in maternal age is often associated with an increased risk of gestational diabetes diagnosis. If we zoom out to look over the last decade from 2011 to 2012 and 2021 to 2022, we will see a steady increase in the incidence of gestational diabetes. And this graph is also representative of those statistics from before. But this rise itself cannot be explained by a single factor. It's most likely due to a combination of things. An increase in maternal age, as suggested by the previous graph, rising rates of maternal BMI, which indicate overweight and obesity, and also a growing population of high risk ethnic groups in our population as well. So, the key takeaway here is that due to the incidence of gestational diabetes increasing amongst Australian populations, as health professionals, we are likely to see presentations more frequently in our practice. So, this makes this conversation that we're having today even more relevant. So, when it comes to gestational diabetes, there isn't just one cause. Instead, there is a combination of factors that can increase a woman's likelihood of developing gestational diabetes. Some of these are non-modifiable, like age or family history. Others are modifiable, like weight or certain lifestyle factors. And some are more complex, such as hormonal conditions or medications. So, in today's presentation, we'll be discussing some of the following risk factors as indicated on this slide: PCOS, family history of diabetes, overweight or obese BMI, and maternal age over 40. Additionally, we'll also be looking at the relationship that certain medications, ethnicity, and macrosomia has on gestational diabetes development. And you might also be wondering why eating disorders is also included on here as well. But I understand that traditionally eating disorders haven't been listed in the classic GDM risk factor bullet points, but research is definitely beginning to show that women with eating disorders, particularly bulimia nervosa or binge eating disorder, may have a unique physiological and also behavioral pathways that increase their risk of GDM diagnosis. And these pathways will be outlined later on. On top of this, the psychosocial burden as well of an eating disorder can also affect how well someone is able to engage with dietary recommendations during pregnancy, which also adds another layer of complexity. So, whilst eating disorders may not be as commonly discussed as other risk factors, they are clinically significant and we need to keep them in mind, particularly since up to 7.5% of pregnant women are estimated to have some form of an eating disorder. So, if we use statistics from 2023 from the Australian Institute of Health and Wellbeing, out of the 281,099 Australian mothers who gave birth in 2023, up to about 21,000 of those mothers may have had some form of eating disorder during their pregnancy, which can complicate both maternal and also fetal health outcomes. So we'll move on and take a closer look at some of these risk factors, and we'll start off with polycystic ovary syndrome or PCOS. So the official definition that the RACGP uses to define PCOS is based on the Rotterdam criteria. And for a PCOS diagnosis, two out of the three criteria need to be met. Hyperandrogenism is the first criteria, and this is defined by elevated free testosterone from blood tests or clinical symptoms that present because of elevated testosterone. This can include, but is not limited to, hirsutism, acne, androgenic hair loss, which is visualized as thinning of the hair, particularly on the top of the scalp and near where the hair parts. And many of these clinical symptoms can actually be observed visibly. However, some women with elevated free testosterone may not actually have any clinical symptoms accompanying this. Oligo or anovulation is also the second criteria, and this is characterized by menstrual cycle length less than 21 days on average or greater than 35 days on average. So oligoovulation refers to infrequent ovulation, whereas anovulation is the complete absence of ovulation. In PCOS, ovarian dysfunction is typically what contributes to this, with the hormonal imbalances often affecting the development and also the release of eggs from the ovaries. Women with regular menstrual cycles may also be at risk of oligo or anovulation, as the presence of a menstrual cycle does not actually guarantee ovulation. And with polycystic ovaries on an ultrasound, this is the third and final criteria. And it is important to note that despite its actual name, not every single individual PCOS will have polycystic ovaries. And additionally, polycystic ovaries do not actually suggest there are multiple cysts on the ovaries. Rather, the name suggests the presence of 10 or more antral follicles on each ovary. So these follicles often fail to mature and release an egg due to the hormonal imbalances. So, in women with PCOS, several mechanisms often drive this increased risk of gestational diabetes development. So, the below infographic outlines the mechanism and pathways, particularly with hyperandrogenism and increased risk of gestational diabetes during pregnancy. So, this pathway here represents obviously high testosterone levels contributing to the elevated blood sugar levels. So, essentially, elevated testosterone and other androgens can worsen insulin resistance, and the chronic inflammation actually contributes to metabolic dysfunction as well. With the lower levels of sex hormone binding globulin or SHBG, this leads to higher circulating free androgens, which creates a bit of a feedback loop. And then with the pregnancy hormones layered on top of this, it sort of creates a bit of a perfect storm for impaired glucose tolerance. So the end result is elevated blood sugar levels and in many cases gestational diabetes if this process happens during pregnancy. In general, these statistics indicate that between a 2 and 3 fold increased risk of gestational diabetes for PCOS patients. And statistics have generally stayed stable within the last 2 decades as well. Therefore, for us in practice, if we do see a woman with PCOS, especially if she also has other modifiable and non-modifiable risk factors like higher BMI or family history of diabetes, we need to be proactive about screening and also intervention as well. Family history is another strong predictor of gestational diabetes, and we often define this as having diabetes in a first degree relative, so your parents, children, or siblings, or a second degree relative, such as grandparents, aunts, or uncles. So, from a clinical perspective, family history can give us some insight into both genetic and also environmental influences. And genetics can play a major role in glucose regulation, but family history can also reflect some shared modifiable lifestyle factors, such as diet and also physical activity patterns. And women with a family history of diabetes are anywhere between about 2 and 4.5 times more likely to develop gestational diabetes compared with women who don't have an existing family history. So, when we're taking a history or patient history in antenatal care, it's important not to just ask, do you have diabetes in your family, but to also clarify who, how many, and at what age they were diagnosed, as this can give us a bit of a better sense of the woman's underlying risk. So, next, let's talk about body mass index. In Australia, being overweight is indicative of a BMI of 25 to 29.9, and obesity is indicated by three separate classes from 30 upwards. For certain ethnic groups, the cutoffs are lower. So, for example, women of an Asian background may have a higher risk at just a BMI of 23 to 27.4. And this is likely a result of genetic variations in body fat percentage and also body composition, as well as the physical differences in the build of an individual from a different ethnic group. And body mass index itself is a measure of body fat that's based on height and weight. However, it is definitely noted to have its own flaws with its ability to fully capture the health profile of an individual. So, for example, women with a higher lean muscle mass may technically fall into the overweight range, but her actual metabolic risk could be lower than what her BMI actually suggests. And conversely, women with a higher body fat percentage, especially visceral fat, may be at a higher risk even with a normal BMI. So, BMI itself is not a perfect measure of diabetes risk or health profile. Rather, it should be used as part of a screening tool alongside other additional comprehensive health assessments in order to determine or properly determine the risk of diabetes and gestational diabetes development. So, in women with a BMI indicating overweight or obesity, there are several mechanisms which drive this increased risk of gestational diabetes development. So, this infographic essentially outlines the mechanism and pathways behind a higher body fat percentage with a overweight or obese BMI and why that contributes to an increased gestational diabetes risk. So essentially, with the excess body fat, in particular, central or visceral fat, this can drive insulin resistance through several mechanisms. So, the adipose tissue or the fat tissue can produce inflammatory cytokines that reduce insulin sensitivity. And then also, the pregnancy hormones add an additional insulin resistant state. And as a result, blood glucose levels can rise much more easily during pregnancy. Systematic reviews and also some meta-analyses have consistently shown that the risk of GDM rises in a dose-response relationship with BMI. So, for example, one large review found that women who had a BMI indicating obesity before pregnancy had up to about a 3 time higher risk of developing GDM compared with women with a BMI that indicated a normal body weight. So the higher the BMI of a woman pre-pregnancy, the more likely the risk of just developing gestational diabetes. This risk can increase by more than double if the BMI indicates obesity class 3. And the message here is not about stigmatizing weight per se, but rather about recognizing BMI as a clinical risk marker that can help us plan screening and also early intervention where appropriate. With maternal age, this is also another well-established risk factor. So this is defined as the age of a mother at the time of giving birth. And statistically in Australia, more women are having children later in life. So according to ABS data, the average age of mothers has been steadily rising, and the proportion of first-time mothers over 35 also continues to increase. So, in women with a maternal age of 40 or over, several mechanisms can drive this increased risk of gestational diabetes development. So, this infographic will outline the mechanism and pathways behind a higher body fat. This infographic outlines the mechanism and pathways between a higher age and also elevated blood sugar levels. So, as women age, there are natural changes, obviously, in glucose metabolism, and pancreatic beta cell function can naturally decline with age, reducing the body's ability to produce insulin. And at the same time, insulin sensitivity also tends to decline as well. So, when we layer pregnancy hormones on top of this, the risk of impaired glucose tolerance can naturally elevate as well. And this graph was highlighted earlier in the presentation, but is obviously relevant to the risk factor that we're currently discussing as well. And this data shows that women aged 35 and older are about 2.5 to 4 times more likely to develop GDM compared with younger women. So to summarize so far, PCOS, family history, BMI, and also maternal age are all strong and well-established risk factors. When we move on to another risk factor, we're going to discuss medications as our next one. So, certain medications can also increase the risk of gestational diabetes as well. Two of the most common categories we encounter are corticosteroids or antipsychotics as well. And these medications can have significant effects on glucose metabolism. And when combined with the natural insulin resistance of pregnancy, they can increase the likelihood of gestational diabetes. So these steroid medications are widely used in conditions such as asthma, eczema, lupus, rheumatoid arthritis, and also inflammatory bowel disease. And they mimic the effects of cortisol, which is the body's stress hormone, and they're often prescribed to reduce inflammation in the body. Hence, their prescriptions for many of these inflammatory conditions. And due to their ability to mimic cortisol, they may also be prescribed for conditions where there is also low cortisol, such as Addison's disease. Antipsychotic medications are also another group to be mindful of. So these include drugs such as olanzapine and risperidone, and they're used for conditions such as schizophrenia and bipolar disorder. So women on long-term antipsychotics often enter pregnancy with an elevated baseline risk, which is then compounded by pregnancy hormones. So again, this is all about awareness. If we're working with women who take these medications long term, we should be flagging them as a higher risk and ensure they're closely monitored during pregnancy. The mechanism for corticosteroids is outlined on this slide, and these drugs are effective at controlling inflammation, but they do often come with some metabolic side effects as well. So, because the medications mimic cortisol in the body, they reduce the body's sensitivity to insulin, and this can contribute to an increase in hepatic glucose production, which means the liver can naturally release more glucose into the bloodstream. And when combined with pregnancy hormones, this can make it even harder for a woman's body to maintain normal glucose levels. And this doesn't mean that these medications should be avoided, and they absolutely may be medically necessary in many instances, but it does mean we need to be vigilant about screening women who are on these medications. And for antipsychotics, the mechanism for increased risk of gestational diabetes stems from body fat percentage and shifts in body composition. So these medications can affect body fat percentage through a variety of mechanisms, both related to appetite and also shifts in metabolism. So antipsychotics can interfere with appetite regulation, leading to an increased appetite and also cravings, and they can also alter fat storage as the medication can promote more visceral fat accumulation or central fat accumulation, and this is often affiliated with insulin resistance. Additionally, insulin production can be impaired through a direct impact on beta cell functioning, and a combination of all these factors coupled with pregnancy hormones can increase the risk of elevated blood sugar levels. Another important factor as well to consider is ethnicity. So, ethnicity is more than just a label. It reflects shared genetic, cultural, dietary, and also social characteristics. And these can include things like shared ancestry or geographic locations, cultural traditions, language, and also religion as well. And in many cases, minority or disadvantaged status within society. So, all of these sorts of factors can influence health outcomes, including gestational diabetes risk, through both a combination of modifiable and non-modifiable factors. In Australia, the data shows that about 16% of First Nations women who gave birth in hospital were diagnosed with gestational diabetes. So, this is a strikingly high prevalence compared to the national average, and it reflects not only genetic predisposition, but also some broader social determinants of health, such as access to nutritious food, healthcare services, and also culturally safe healthcare. So, this highlights the importance of considering cultural context when supporting women during pregnancy. And the AIHW data also shows that women born in Southern and Central Asia, Southeast Asia, North Africa, and the Middle East and Northeast Asia were between 1.4 and 2.2 times more likely to be diagnosed with gestational diabetes compared to women born in Australia. So, this can be explained by both genetic and also environmental factors, which increase the risk of gestational diabetes. So, for example, genetically, some ethnic groups have higher baseline insulin resistance, and others also retain more abdominal fat or visceral fat around the midsection naturally. And environmentally as well, migration can also involve significant dietary and lifestyle changes. So, for example, adopting more processed foods, potentially reduced physical activity, or just different stresses associated with moving to a new country. So, when we consider risk assessment, ethnicity is an important non modifiable factor that should definitely guide us towards earlier screening as well. Now, we'll move on to macrosomia. So, this refers to a high birth weight infant. And there isn't one single definition globally, but in Australia, we use either a birth weight of over 4,000 grams or a birth weight of over 4,500 grams. So, according to some recent statistics, 1.3% of all babies born in Australia in the year 2023 were actually of a macrosomic birth weight of 4,500 grams or greater. And the statistics favor healthy birth weight heavily. However, it is also important to note that the definition of a healthy birth weight actually includes a macrosomic birth weight by clinical definition. Therefore, it's not really possible based on the most updated data set to highlight what percentage of this 92% of women that gave birth to a normal birth weight baby that were obviously of a macrosomic birth weight. And macrosomia is both an outcome of also GDM and also a potential risk factor for GDM in future pregnancies. So, if a woman has previously delivered a macrosomic infant, especially if she wasn't actually diagnosed with GDM at the time, that's a strong clinical indicator that she may be at risk in subsequent pregnancies. And research often shows that macrosomia without gestational diabetes during pregnancy can still be a predictor of future gestational diabetes diagnosis. So, one study actually found that non-diabetic women who had a macrosomic infant were nearly about twice as likely to develop gestational diabetes in a subsequent pregnancy compared to women without a macrosomic infant. And this suggests that in some cases, gestational diabetes may have actually been underdiagnosed or underdetected during the original pregnancy, because macrosomia is not just an outcome of gestational diabetes. It can also be considered a red flag for future risk, and it's also an important part of the woman's medical history that we should pay closer attention to. And the factors contributing to macrosomia are also tied heavily to risk factors for gestational diabetes. So things such as pregnancy hyperglycemia, excessive weight gain during the gestational period, insulin resistance, and also an elevated maternal BMI. These are all contributors to the development of a macrosomic infant. Excessive weight gain and high maternal BMI are often suggestive of a higher body fat percentage and shifts in body composition, which can naturally increase the risk of insulin resistance. So, a combination of one or all of the above factors can elevate GDM risk for subsequent pregnancies. And when a woman is diagnosed with gestational diabetes, the link between this condition and macrosomia is largely driven by maternal hypoglycemia. So, this is initially triggered by maternal insulin resistance affecting overall blood glucose control during pregnancy. Other factors such as maternal weight gain, maternal BMI, and family history, when coupled with the pregnancy hormones, can also impact blood glucose control during pregnancy and lead to the diagnosis of gestational diabetes. And when we look at some studies surrounding macrosomia, one study found that non-diabetic women who had a macrosomic infant were nearly more than 3 times likely to develop GDM in a subsequent pregnancy compared to women without a macrosomic infant. So that, therefore, this suggests that in some cases, GDM may obviously be underdiagnosed or potentially underdetected during the original pregnancy. So macrosomia is not just an outcome. Like I said, it's also an important part of the woman's medical history that we should pay close attention to, especially when screening for gestational diabetes risk. And I'll move on to eating disorders as well. So, eating disorders, they are a complex and potentially life-threatening condition, and they're characterized by significant disturbances in eating behavior and can result in very serious medical, psychiatric, and also psychosocial consequences. So, the DSM-5 actually defines several main categories. So, there's obviously anorexia nervosa, bulimia nervosa, binge eating disorder, OSFED, which is known as Other Specified Feeding or Eating Disorder, ARFID, which is known as Avoidant Restrictive Food Intake Disorder, and also a broader general term known as Unspecified Feeding or Eating Disorder. So you might be again thinking, why are we talking about eating disorders in a session on gestational diabetes? And the reason is that eating disorders obviously have a direct impact on metabolic health. They can alter insulin sensitivity, body composition, hormonal balance, and even weight regulation, all of which interact with the physiological changes of pregnancy. And as I mentioned earlier, eating disorders are actually not rare in pregnancy. So studies show that up to about 7.5% of women actually suffer from an eating disorder or some form of an eating disorder. So that means in a room of, say, 20 to 25 pregnant women, one or two of them may actually be affected. And for us clinicians in community settings, this is actually very highly relevant as well. And when we look at prevalence data more broadly, around 1 million people in Australia are living with an eating disorder at any given time. 2 out of 3 are female, and the lifetime prevalence of anorexia nervosa is about 3%, and bulimia and binge eating disorder are much more common in the general Australian population. So, whilst they are not always visible, eating disorders are not niche conditions. They're actually part of the clinical landscape that we work in. And today we'll obviously discuss a little bit more about that. So, just in terms of why this is obviously related to gestational diabetes, in terms of nutritional status, chronic restriction or malnutrition can obviously affect glucose metabolism. Weight cycling and binge eating can increase, obviously, visceral fat and insulin resistance. The hormonal disruptions that occur as a result of eating disorders can alter sex hormones, cortisol, and also appetite regulating hormones, all of which can interact with the pregnancy hormones as well. Not to mention the psychosocial challenges that women can go through when they are diagnosed with an eating disorder, as it can make it much more difficult to engage with traditional management strategies such as tracking blood glucose and following structured meal plans. So, eating disorders, particularly binge eating and bulimia nervosa, are definitely a risk factor for GDM, not just because of biology, but also because of the behavior and treatment complexity that's associated with these conditions. So, I'll just briefly go over some of the diagnostic criteria for the common eating disorders. So, anorexia nervosa obviously is defined as the restriction of energy intake that's resulting in a significantly low body weight or less than minimally expected weight based on their age, their sex, or their developed trajectory. And there's often an association of an intense fear of gaining weight or any sort of persistent behavior that actually interferes with weight gain despite their low weight. And there also are often some disturbances in body image or a lack of recognition of the seriousness of the situation. With bulimia nervosa, this is characterized by recurrent episodes of binge eating. So, this involves essentially eating an excessive amount of food in a discrete period of time and also a sense of lack of control. And then, as a result of the binge eating, there will be recurrent inappropriate compensating behaviors to prevent weight gain. So, this can involve the use of laxatives, this can involve purging, use of diuretics, fasting, or excessive exercise. And a frequency of at least once a week for 3 months is needed to be diagnosed with bulimia nervosa. And also, as well, there needs to be the absence of anorexia nervosa as part of this diagnosis. And with binge eating disorder, there needs to be recurrent episodes of binge eating, which again, I've already identified above in terms of what that is classified as. And this binge eating disorder is often associated with symptoms such as eating more rapidly, feeling almost uncomfortably full, not feeling hungry, eating alone due to embarrassment or feelings of guilt and also self-disgust. And there's also a lot of distress associated with the action of binge eating. And the frequency of this binge eating needs to happen at least once a week for 3 months. So today we'll just be looking at two eating disorders that are most prevalent in the Australian population and the impact that such eating disorder behaviors can actually have on gestational diabetes risk. So this flowchart illustrates a pathway explaining how bulimia nervosa may increase vulnerability to gestational diabetes, not necessarily as a direct cause, but obviously more as a contributor to metabolic risk over time. So with the recurring binge eating episodes, these episodes often involve large amounts of rapidly absorbed carbohydrates, which lead to sharp postprandial spikes in blood glucose and insulin. And even when compensating behaviors such as vomiting or fasting occur afterwards, the glucose absorption has likely already taken place, meaning the metabolic exposure actually remains. So over time, this pattern of binging and compensating naturally contributes to the weight cycling, and it is associated with an increased visceral fat accumulation and greater insulin resistance, even in individuals whose overall body weight appears normal. And the repeated metabolic stress places an increased demand on the pancreatic beta cells, which are responsible for insulin secretion. And over time, this can impair beta cell function and reduce the body's ability to compensate for insulin resistance. The pregnancy, or I guess the situation of pregnancy, then introduces a second unavoidable metabolic challenge. So the placental hormones obviously naturally increase insulin resistance to prioritize glucose delivery to the fetus. And in most pregnancies, the pancreas adapts by producing more insulin. However, in individuals with pre-existing insulin resistance or beta cell vulnerability, this adaptive response may be insufficient. So the result is an exacerbation of insulin resistance and increased risk of gestational diabetes development. But this pathway does not suggest inevitability, but rather highlights how long-standing metabolic stress, particularly with the binge eating behaviors, can actually intersect with the physiological demands of pregnancy. And binge eating disorder is characterized by recurring episodes of consuming large quantities of food, typically foods that are high in refined carbohydrates and fats without compensating behaviors. And as a result, these episodes lead to repeated postprandial spikes, as I've mentioned before, in blood glucose and insulin. So, over time, this pattern can promote chronic hyperinsulinemia, and persistently elevated insulin levels are not benign. They often drive insulin resistance and also favor fat storage, particularly in the visceral compartment. And with the visceral fat, this is metabolically active, so it can release free fatty acids and inflammatory mediators that interfere with signaling and also increase the demand on the pancreatic beta cells. And over time, this can create a state of baseline insulin resistance combined with the reduced beta cell flexibility. The pregnancy then introduces obviously a normal but significant metabolic change with the placental hormones, and the result is an exacerbation of insulin resistance and a higher likelihood of gestational diabetes development. So now we'll shift onto the diagnostic criteria. So this is an important area because recently the Australasian Diabetes in Pregnancy Society, or ADIPS, they released a new consensus statement, I should say, in 2025, and this has been endorsed by the RACGP. So the key update is that the criteria for screening and diagnosing gestational diabetes has been revised. So the most important points I've obviously summarized here on this slide. So overt diabetes in pregnancy is now distinguished from gestational diabetes. So this actually means that if a woman's blood glucose levels are in the diabetes range, the same as if she were not pregnant, she is diagnosed with overt diabetes, not GDM. And this represents more severe hyperglycemia and also carries some different implications. Universal screening as well at 24 to 28 weeks remains standard, and therefore we will be using the 75-gram oral glucose tolerance test. And earlier screening is recommended if a woman has strong risk factors. Thresholds are also slightly higher than earlier criteria. So the fasting cutoff is now 5.3. Previously it was 5.1. 1 hour cutoff is now 10.6, and then 2 hour cutoff is now 9. So these changes may seem small, but they do significantly affect who receives a diagnosis and therefore who enters the traditional GDM care pathways. So these recommendations come from two key sources. So this flowchart here, and also I've linked the source in terms of the journal article to help you better understand that. But this is something that you can look at in your own time. So the RSCGP guidelines for overt diabetes and gestational diabetes are outlined here. So the RSCGP guidelines have actually incorporated the new criteria into their practice recommendations. So when you're documenting or when you're referring women, you can be confident that these are the endorsed national standards moving forward. So now that we've reviewed the diagnostic criteria, we'll move on to some management strategies. And this is very much a question of how do we support women once they have a diagnosis of gestational diabetes, and also how do we tailor our approach when the eating disorder is also in the picture. So referrals are obviously a cornerstone of good gestational diabetes management, and one of the very first steps as part of the management pathway as well. So ideally, every single woman with GDM should be referred to an accredited practicing dietitian who can provide tailored dietary advice, and also a credentialed diabetes educator who can guide her through blood glucose monitoring, insulin use if needed, and also some practical day-to-day strategies. And also, as well, don't forget enrollment with the National Diabetes Services Scheme, so or the NDSS. So this gives women subsidized access to blood glucose monitoring supplies and also connects them with educational resources. And for many women, these referrals are what make the difference between feeling alone and unsupported versus feeling guided through what can understandably be a stressful time. Once a woman is diagnosed with gestational diabetes, education can also play a pivotal role as well to support management. So this is not just about telling someone that they have high blood sugar level, it's about empowering them with knowledge so that they understand the condition and also feel capable of managing it. So we will obviously want to say that in terms of the importance of relevant lifestyle changes and risks associated with a condition, education on what gestational diabetes actually is and why it happens is important. Education on the role of lifestyle changes, such as diet and physical activity, why gestational weight gain needs to be monitored but also kept realistic, and also the possibility that medications such as insulin, metformin may be needed if lifestyle alone isn't enough. So we need to be careful, obviously, with how we frame this education because the goal is to support and encourage, not to overwhelm or shame or make more anxious because a lot of women already feel anxious when they receive a diagnosis of gestational diabetes, and adding guilt can obviously reduce engagement rather than improve it in many instances. So, a bit more of a practical approach here includes using simple, clear language, so avoiding things like jargon wherever possible, providing a lot of written resources because often it's too much to absorb in one sitting when we're just talking at a client, using visual aids to make dietary advice tangible, and also involving partners or family members or their close support network as much as possible so that the woman feels supported at home or within their social network. And one of the most powerful things you can do is reframe the conversation as well. So instead of saying you have to cut out sugar completely, we can say we want to stabilize your blood sugar so that you and your baby stay healthy, and here are some strategies that will help. So just a little change in tone and also sometimes a change in wording is a small shift, but it can make the advice feel much more achievable instead of a mental load for the client. And follow up after pregnancy is also critical as well. So, too often, once the baby is born, the mother's risk is forgotten. So, we often would recommend, or the ISCGP would also recommend, that there should be a 6 to 12 week postpartum oral glucose tolerance test. And if the oral glucose tolerance test is normal, fasting glucose and HbA1c should be checked every 3 years moving forward. If HbA1c is 6% or higher, closer monitoring and earlier intervention is warranted. And for women planning a subsequent pregnancy, an annual oral glucose tolerance test is advised to ensure early detection. So, moving on to obviously the eating disorder management, these require obviously a bit of a nuanced approach in gestational diabetes management. So, with women with gestational diabetes, they're already at a risk of developing disordered eating patterns, even if they don't have a pre-existing diagnosis of an eating disorder. So, the constant focus on often numbers, blood glucose targets, weight, food choices, etc., can often feel like medically sanctioned food restriction. And for a lot of women with a history of eating disorders, this can actually be particularly triggering as well. So they may find things like glucose monitoring stressful, or they may actually start to view things like foods as good or bad in very rigid ways as well. And it's also important to know that there are often some key drivers as well in clinical settings. So things like internal drivers, like their own risk perception, things like low self-efficacy with managing their diet in a flexible manner, and also that emotional distress and also loss of control. And external drivers may be rules or dietary suggestions imposed by healthcare advice, a strong social pressure to be perfect with a diet during pregnancy, and also conflicting messages from either from their inner social circle or potentially things they see online as well. So, what can we do? We can obviously use non-stigmatizing language. So, avoid moralizing food as good or bad. Create a supportive environment as well where women feel safe disclosing their concerns. Screen for eating disorder risk factors. So, tools like the SCOFF questionnaire can be helpful. And also, as well, be flexible. So, for some women, it may not be appropriate to push strict calorie or carbohydrate counting onto them. The goal, really, at the end of the day, is to manage blood glucose without exacerbating or re-triggering an eating disorder. And a multidisciplinary approach is obviously essential as well when eating disorders and gestational diabetes intersect. So, key team members would obviously include a general practitioner, a dietitian with expertise in both diabetes and eating disorders, diabetes educators, psychologists, and also other allied health or medical specialists as needed. And there's also structured support pathways that we can also use as well. So, the chronic condition management plan, eating disorder management plans, and also a mental health care plan as well in exceptional circumstances. And once acute symptoms are managed, a referral to programs like Life After Gestational Diabetes is also an option as well. So the key is early recognition and connection to the right supports is definitely important in the management of eating disorders in the context of gestational diabetes rather than trying to manage everything in isolation. So I'll just move on to obviously the final section of today's session, which is just a little brief overview of the Life After Gestational Diabetes program. So this is a program which is designed to provide long-term support for women after pregnancy. So in terms of the ongoing risk of the ongoing risk after gestational diabetes, 60% of parents who had gestational diabetes will often go on to develop pre-diabetes or type 2 diabetes within 10 to 20 years. There's a twofold increased risk of heart disease and also a 70% chance of developing gestational diabetes, again in subsequent pregnancies. So this is why essentially the program was developed. So, if you're not already familiar with the LIFE program, it is the largest type 2 diabetes, heart disease, and stroke prevention program in Australia. And it's Victorian government funded and delivered by Diabetes Victoria. And it is also a free program as well. So, there is no additional cost in terms of referring or enrolling enrollment in the program. We have qualified health professionals like dietitians and exercise physiologists delivering the program. And the program is very much centered around developing health behaviors that are sustainable and also contributing to a reduced risk of developing diabetes, heart disease, and stroke. So, with the Life After Gestational Diabetes program, this is delivered online to a small group of parents who have had gestational diabetes and is tailored to the needs of busy parents and currently delivered in English and Vietnamese. And in terms of eligibility criteria, you have to be living in Victoria as it is a government funded program. You have to not be diagnosed with type 1 or type 2 diabetes, and you need to just have a history of gestational diabetes to be eligible. The program is structured to be a 12-month program. So essentially, there's a one-to-one introduction where the client would obviously meet one-on-one with the facilitator to discuss their health goals. And then basically from weeks 1 to week 7, the group would meet fortnightly and education sessions are provided, whilst also tailoring the education to individual goals that were discussed in the first session. So those education sessions are centered around understanding the risk factors that are modifiable, nutrition, physical activity, and also mental well-being as well. And then there's a little bit of a break in between where there's still obviously opportunity to touch base with the facilitator, but everyone would regroup at the 6 month mark where they would discuss any challenges that they've experienced over those past couple of months. And then session 6 is a catch up at the 12-month mark, which is essentially a bit of a discharge from the program to ensure that necessary supports are in place to continue supporting them with their health goals moving forward. So, in terms of referring to patients, you can obviously direct patients to the Life website, or you can obviously just have that QR code in the clinic or in your office, etc. But basically, it's recommended to complete any diabetes checks before starting the Life After Gestational Diabetes program, just to rule out any diabetes diagnosis. And resources as well can also be ordered online. So if you would like to promote these in your clinics or have these in your office, then you can obviously order them online through the website. And there's no delivery fee as well. They're free to deliver to you. All right. And that concludes the presentation.
Thanks, Wendy, for the presentation tonight. If anyone has any questions, feel free to pop them in the chat and I'll read them out to Wendy. But in the meantime, I might just go through some Murray PHN resources. So we've got Health Pathways is a free web-based portal available for use by clinicians at point of care to access evidence-based, locally accessible patient pathways. If you do not already have a login, access can be requested via the website displayed on the screen. More than 900 pathways have been localized for the Murray PHN region with input from more than 100 health professionals. Onto the next slide, please, Wendy. I'd like to share some information on digital health to support the healthcare practitioner. A range of digital health resources are available on the Murray PHN and Australian Digital Health Agency websites, including information on requesting e-referral, e-scripts, cyber security, My Health Record, emergency and natural disaster digital toolkits, telehealth, and more. So please reach out to our digital health consultants for support and to discuss any queries via the email shown on the screen. We'll also include the contact details in the post-webinar email. Next slide, please. So for general practices now, the content from this webinar could form part of a quality improvement activity. So please reach out to your quality improvement consultants for further information. And finally, next slide, to assist Murray PHN in planning future CPD events, please provide your feedback about today's webinar by scanning the QR code on the screen or by completing the survey that you will be redirected to after this webinar has ended. And for upcoming webinars, please check the Murray PHN website. And if you haven't already, you may like to subscribe to our events update, which can also be done on our events and education webpage. It looks like no questions have come through, Wendy. So we might just wrap up the webinar there. So on behalf of Murray PHN, thank you, Wendy, for presenting the webinar tonight. We greatly appreciate your time in delivering this, and thank you all for attending. Have a good evening.